And I was asked to talk a little bit about expanding the frontiers of technology-assisted surgery. Now, I know there's a robotics course, and I'll talk a little bit about robotics. I have a little bit of a different opinion sometimes. I use a lot of navigation, augmented reality, and I think robotics is definitely an important adjunct to what we do in surgery, but I also want to put out a few words of caution and maybe point out that there's a lot of technology out there beyond robotics, and I think at the end of the day, we probably have to integrate, and I think that's going to be really the key for robotics to expand and really be valuable for what we do as surgeons. There's a slide that we put together for a book cover that kind of summarizes a lot of the technology that goes especially into minimally invasive spine surgery. And there's a lot of technology, of course, navigation, robotics, augmented reality for tumor, for degenerative spine. So it's very, very exciting. This is one of my favorite slides that summarizes really the landscape of spine surgery, not only MIS, mainly degenerative and deformity. So if you look at the complexity of spine surgery and you go from low complexity operations to high complexity and you plot that against the invasiveness, you see that with open traditional surgery, that invasiveness goes up pretty quickly. The whole point of MIS is to dampen that curve. And I think we're doing a really, really good job in the middle curve of complexity. So for me, those are operations that involve a 1, 2, 3 level fusion for degenerative disorders, for example. So I think that's the benefit zone for minimally invasive spine surgery. And if you look at technology, I think especially navigation, robotics, augmented reality now really spans the whole spectrum of spine surgery, from low complexity to complex deformity. This is totally different from 10, 15 years ago. Microscope, tubes, of course, I'm a big tubular surgeon. Endoscopy is very, very exciting. And then implants, lateral expandable technology. So you can see that technology really is an adjunct to all types of spine surgeries, not only high complex or low complex. It's really, it spans the whole spectrum, especially when it comes to navigation. And for the purpose of this presentation, I want to walk you through a typical MIS TLIF procedure that, again, I think is really at the core of MIS and really the MIS benefit zone. And we don't use we don't use robotic surgery currently, but we use a lot of navigation, and that's obviously closely related to robotics. But the point is that we're trying to use navigation to make the workflow easier. So we use navigation from the very beginning of the procedure to the very end. So we call that total navigation. That requires that you stabilize the patient very carefully. We use this particular navigation system, but in the group now, we're 8 spine surgeons. We have 6 navigation systems. So we use navigation for almost every case. So the key is really to tape the patient so there's no movement. That increases the accuracy. And I'll walk you through a typical MIS TLIF procedure. And this is all now on AO surgery reference, by the way, for MIS TLIF. You can look that up on the AO reference app. And it's really standardized, and it's totally protocolized and with and without navigation. I'll show the workflow with navigation. So we start by we put the reference array into the iliac crest. We make 2 lateral skin incisions in the perfect trajectory for the pedicle screws, and then I use a single pass pedicle screw system. There are a number of different companies out there that make these pedicle systems available. And I like it because you can use tactile feedback. So I make the incisions, I can feel with my fingers the entry point, and then I use navigation to maximize, obviously, the trajectory and the accuracy of the pedicle screw placement. So I don't rely on robotic surgery for that part. And why don't I? Because I think that the tactile feedback is very, very important. So there are instances, like in this case, for example, where the pedicle screw is a little bit lateral. I want to reposition that. That would be very difficult with robotic surgery. But with tactile feedback and with the navigated single-step pedicle screw, I can feel the perfect entry point. I can see it on the screen. And then with this navigated all tip tap, which is a very, very aggressive instrument, but I have it under perfect control because of the tactile feedback. I can then redirect this pedicle screw into this adjacent pedicle a little bit more medially and get a really nice result. So for me, that works very, very nicely. I'm a little worried about robotic surgery because it can kind of become a problem. As you can see, you can't stop it and you're not in total control. Anyway, probably I shouldn't show that at a robotic course. I apologize. But there are concerns with robotic surgery. This is Juan Uribe. He posted this. This is not his case. It's a different case. My concern is just the lack of haptic feedback, and with robotic surgery. And there are some data in terms of looking at complications, cost effectiveness of robotic surgery. There's a very interesting paper that was published recently that looked at retrospectively at 300 cases from various institutions where they compared open MIS and robotic surgery. And they found when they looked at cost effectiveness that MIS surgery was superior to just robotic surgery in terms of cost effectiveness. And that was especially because of a lower complication rate and the high costs associated with getting a robotic system into the hospital. So I think we have to look at that. And I'm totally open to robotic surgery, but I think we still have to do a lot of work to really make this a success. Again, so now let's continue with our MIS TLIF case. So we continue to put in the screws with navigation. Then I use navigation to put a tubular retractor here, the reference array in the iliac crest. We bring in the microscope, and then under the microscope, I do the facetectomy again. And this is all protocolized now in the AO surgery reference for those surgeons who want to look that up, and maybe for residents and fellows. It's very nicely documented now. So we do it always the same way. And then we plan the cage. Use a lot of autograft bone from the facet joints, sometimes BMP, and then put in expandable cages. And if needed, we'll do an over-the-top decompression with through the tubular retractor if you have to decompress the contralateral recess or a foraminotomy. And these patients obviously do very, very well. Now, expandable technology is another piece of technology that I think, especially for MIS surgery and especially for TLIF surgery, is very important. And there has been a lot of development. And I want to show you just the comparison of two expandable cages. This is an older generation expandable cage that expands in height. The cage below is a newer generation expandable cage that expands in height and in lordosis. And we looked at both. We looked at a series of patients that we operated on, 35 patients with the older version of the cage and 40 with the more recent cage that expands in height and in lordosis. And these were all MIS TLIF cases. And you can see with the cage that expands in terms of lordosis, you actually get a much better lordotic result. And that's especially for MIS TLIF, that's obviously very important because that is somewhat the limitation of doing MIS TLIF surgery in the past, the difficulty of really getting focal lordosis at the level that you treat. And I think now with those, and this is just the beginning. I mean, that technology is expanding, right? In terms of the our technical ability to really put these cages in there. This is a case that we did recently at L5S1 where we got a very nice result. Now, I want to expand a little bit into augmented reality. So we use a lot of augmented reality now, and there are different ways of utilizing augmented reality. The one way of doing it, which is commercially available, is with the head-mounted display. You wear goggles and then use augmented reality to put in pedicle screws. And there are results out there, and that seems to work very well. There's Augmatics, OnPoint just got FDA approval. There are a number of other companies. What we've tried to do is use the microscope and project augmented reality through the microscope into the operative view. And the way that we did that, and we published that recently for MIS TLIF surgery, is to streamline MIS TLIF surgery by showing the surgeon while they're under the microscope doing the facetectomy, by leading the surgeon from one landmark to the next. So not only to put in the screws, but then also to streamline the rest of the procedure that really requires for an MIS TLIF or any TLIF to go from bony landmark to bony landmark. And I want to show you that on this model. These are the bony landmarks that are relevant for TLIF surgery. So the lamina, the pars, the facet joint, the pedicle above, pedicle below, the disc space. So every MIS TLIF procedure, and again, this is also shown in that AO surgery reference now, every MIS TLIF goes from landmark to landmark. So we start from the lamina, we make a cut to the pars, then we go to the facet joint, remove the inferior articulating process, then we look at the pedicle below, the pedicle above, then eventually we'll find the disc space, do the discectomy, and so forth. And these bony landmarks, you can mark on preoperative or intraoperative anatomy with artificial intelligence. Now, you'll be able to automatically mark these bony landmarks, so the pedicle, the disc space, the facet, the pars, and then you project it through your microscope or through your goggles or whatever you use in the operating room to do the operation. You can project these landmarks into the operative field, and that's what we did here. So we're here on the right side at L4, L5 through a tube. We're looking at the facet joint, and this is the inferior edge of the lamina, and this is the pars. So now we have to connect, and you can project these landmarks into the microscope. Now, this is an early version software, so it's a little clumsy what I show you here, but I hope you understand the idea that you can project these landmarks through the microscope. So here you're seeing the pedicle below, the pedicle above. With the pointer now, we're looking at the disc space, and then we're projecting in the disc space now in yellow, and again, the pedicle above and below. This is a little bit clumsy, but we're working on making the software a little bit more robust. And then you can actually guide surgeons for training purposes, but also in the OR, if you have a fellow, you can actually dial in these landmarks as the surgeon kind of moves along during the case. And TLIF is obviously just an example because it has all these landmarks, but you could do this with any surgery, right? And that's really what I'm interested in is augmented reality to facilitate the workflow. I think there's a huge benefit and huge potential. When it comes to robotic surgery, I think there's a role for robotic surgery. There's a thoracic tumor that we operated on recently. So we put in screws from the back, decompressed from the back, and then together with a thoracic surgeon, we used the Da Vinci system, transthoracic, to resect this tumor through the thoracic cavity with a real robot, and that worked perfectly well. And I hope that at some point we'll be able to utilize these types of robots for intradural or intraspinal work as well. We're obviously far away from that, but that's kind of where I see technology going. So again, I don't want to come over as not being a friend of robotic surgery, but I think there's so much more, especially when it comes to total navigation, augmented reality, robotic surgery in the style of Da Vinci. Those are the things that we have to look at in the future. So I thank you for your attention, and be happy to answer any questions or comments.
We there? Roger, it's Pat Johnson. Thank you very much for joining us today. And your enhancement of this technology from year to year has just continuously impressed me. And you know, I'm just wondering how you're going to expand on this. And do you really think that you've come to your pinnacle with navigation? And do you think that actually you're going to move into a robotics at some point with your TLIF? I mean, that's your golden procedure that you do, and you're the world expert at.
Well, Pat, thanks for the kind comments. I think this is just the beginning. I mean, I showed you these slides with augmented reality. You could see the colors, and it's kind of clumsy, and everything is moving. I see what I see in terms of the integration of robotic surgery at some point. You go in the OR and you have all these landmarks identified, and you may use a robot to put in the screws and to find these landmarks. But I think it has to be an integration. It has to be an integration of freehand or active navigation, robotic surgery, augmented reality. I think once you put all that together, you can really facilitate and you can really take advantage of the technology. I think robotic is a piece of the puzzle right now, and it's great to put in screws, but there's so much more to a procedure. And what I find fascinating with augmented reality is just really that it leads the surgeon from step 1 to step 2 to step 3, and we've done that in real spine models. to see with augmented reality whether surgeons believe that makes it easier for them to pick up the procedure, and it does. We have that submitted now as a publication. So augmented reality as a tool in the OR to teach and train surgeons, but eventually I think it'll all come together with navigation and with robotics.
Izzy. Thank you. Izzy's.
Cool. Morning, Roger. Good to see you. It's Izzy Lieberman. Fantastic stuff, and as always, you're charting the course for many of us and helping us pull together multiple technologies. But one of the issues that I've always struggled with is we've been using the same navigation technology for over 50 years. The cameras, the reference arrays, the line of sight issues. When are we going to get away from that? There is so much other technology on the shelf that we can use that can eliminate that one, what I call major speed bump in what we are doing. So when are we going to get away from that mode of navigation?
Yeah, that's a very good question. And we kind of work around it. We make it work, right? But it's certainly not perfect. And there's EM navigation, as you know, that I'm aware of. There are different camera systems. I think most of these cameras that we use are all from the same manufacturer, right? All the different platforms use essentially the same cameras, which is kind of striking. I don't have a good answer, but I totally agree. I mean, that's a challenge, and that requires, I think, a thought process. I don't have a good answer though, but I totally understand. Maybe you have. I mean, you're asking the question for a reason.
Well, I would suggest that we as a group of surgeons prompt the developers, i.e. the strategic companies, and say, let's get rid of these cameras for soon. And there's so much other technology. Start working on the other technology instead of propagating this essentially relic technology. Look around the world. There's every other industrial arena is using way better technology than what we're using in the operating room to navigate. So we've got to get it.
Jeff Larson. Hey, give him the microphone. What, Jeff?
Hi, Roger. Is it Jeff Larson, Coeur d'Alene? Hearing you say this reinforces in my mind that it's more of a regulatory situation that is superimposed on what we do. And in aviation, for example, it's there. Everything's been line of sight, VOR for navigating airplanes to where they're supposed to go. The GPS systems are there and they're as accurate, if not, and they're more dependable, but it's still that leap of faith to say, this is a precision approach. These little devices that we'll have in the OR are now as precise as these camera lines of sight things. So I think you're absolutely right. The technology's there, just getting this acceptance and somehow pushing it through. And it's going to take leaders like yourself to kind of to figure out where that barrier is. But the technology's there for sure.
I'll just Terrence Kim from Cedars. I'll also piggyback on Izzy's concern, Roger, because the idea of dynamic tracking for navigation. So if the human shifts or if the reference frame changes, how you can't really accurately or dynamically mobilize as you're putting your screws in, it starts losing its accuracy, and we've seen this before. And the fear that I have, as I'll bring it out to everyone else today in this robotics course, is robots are based off of this navigation system, right? And so it makes me nervous that it's this house of cards that we're flying on old technology that isn't quite perfected and definitely isn't optimized, as Izzy is saying. And we're kind of starting to build off this, and we don't even have that foundation that's really set.
I want to ask.
My answer to that is really the combination, right, of palpation and navigation. I try to indicate that that's probably not the perfect answer, but that's certainly what I use to make sure that I absolutely make sure that navigation is accurate, or I can pick up inaccuracies just by finger palpation. And the nice thing is that also teaches the residents the anatomy at the same time, so you're not blindly looking at a screen. You put your finger and you feel the anatomy, the transverse process, and you compare that with what you see on the screen. And that's actually a great teaching experience but it doesn't answer the question of how to integrate better technology. In that regard, my concern is that as surgeons, we're not really involved enough in some of this with the companies, that the companies really kind of prescribe, what we should be doing. And that's a big concern with especially some of the European companies I've worked with.
Jens, you have a question? Because I have one last one actually is that talk is about expanding frontiers and I know we need new technology and we need advances in it, but the question is, are we really going to use navigation for everything? I used to give talks about navigation for everything, okay? And actually, I'm doing that now. A lot of my decompression surgery that I do, when you have some kind of funny bony osteophyte in the foramen, you're going to do a decompression. I do navigation from the get-go. In fact, it's the way I localize. I mean, I already do that stuff. I do one almost every week like that, with all the hardware cases we do.
I use navigation for almost, except for microdisc. I use it for MIS lamis. I mean, for any MIS case, or an open or revision case, decompression, because once the workflow is established and you have a team that knows how to work it, and then you can see that your colleagues pick it up and the residents pick it up. So it's a real, I mean, they wouldn't do it if they didn't believe in it.
Jens.
So as the dinosaur here, the anti-cool kid, grandfather that is, I just want to point out, yes, you have absolutely deserved incredible merit for structuring, putting organizational thought into the less invasive surgery realm. So kudos. My next claim for you, my next challenge for you will be to expand the frontiers of actually making the grafts heal and realigning the spine. So what I see a lot, and this week, my fellow sitting in the back can verify that, operated on 4 non-unions of MIS placed cages, partly extruded, partly everywhere, floating in the breeze. And again, what I just don't see is a disc prep being properly done, proper bone graft deployment, and absolutely no realignment. These are just flat collapsed spines where a spacer was somewhat safely shoved into the disc space and rests surrounded by cartilage. So my expanding the frontier challenge to you is to realign the spine when you do less invasive surgeries and actually get a fusion in the intervertebral space by better disc prep.
Totally agree, Jens, of course. That's why I wanted to bring in some of that expandable technology, because that's a challenge with MIS TLIF, right? But I think, again, we're going to get there. But I think what the cases that you're seeing, I think, are cases that are wrong from the very beginning, right? From indication, probably. I mean, and then probably poorly executed technically.
Thanks, Roger. Have a great day.